depending on if you include secondary RLS, other causes of RLS in childhood. So it's a really, really common disorder. It's a very common familial genetic disorder that runs in families, as I mentioned. A lot of studies of kids in particular point to that if you see kids with RLS features, there's an over 70-80% chance that their parents, one of the two parents, is going to have RLS in their family too. So that's the point, that this is something that is incredibly common, has a well understood, not completely understood, but a well understood association to a genetic foundation, which there are two genes that have been associated with this in multiple genomic studies. And those two actually have been found by different groups at different times. I was part of the Atlanta group when we found the genetics in Iceland, which is where I was doing my original research, phenotyping people with RLS. And Dave Rye was the lead author on that, published in 2007 in the New England Journal. That was, big heyday. Lots of people started figuring out what's the complex genetics behind RLS. Turns out we really still to this day don't know what it is that causes RLS, but there are a lot of physiologic studies that are pointing to a dysfunction in dopamine, which is a neurochemical associated with frontal lobe function, ADHD, but also with subcortical, basically spinal cord gating. So keeping sensations that are weird and that are not helpful from getting to cortex. So you don't feel what's going on in your body at all the time because it's not important. When there's an important signal that needs to raise itself to the level of consciousness, those signals are gated by dopamine-based innervation in the spinal cord. So in RLS, what we believe is one of the main understandings is that the dopaminergic activity in the spinal cord is not normal, and that dysregulated dopamine levels allow things to get to cortex, like these weird feelings in your legs that are not actually associated with anything. They're just happening, and they tend to happen while you're at rest, and they tend to make you feel better when you move. So those are the basic clinical correlations that we use to diagnose RLS. The other thing is that it happens in a circadian fashion. So it happens more in the evening and at night than it does during the day. And that's also likely related to the circadian activity of dopamine in the spinal cord. We know that dopamine levels dip in the evenings and at night because it's associated with alertness and wakefulness. So when that happens, it actually is predisposing those already with some dopamine dysfunction for having RLS symptoms that occur at night. And the reason it's so significant is that not only does the dopaminergic innervation affect sensation and movement, but it also affects a part of the spinal cord that's associated with your sympathetic nervous system. And we were just talking about the CPC measurement. So when you go to sleep at night, parasympathetic activity is your rest and restore, recover, your metabolism goes down at night, and that's parasympathetic activity is important for generating the cortical changes that we associate with healthy sleep. Well, when you have RLS, you have sympathetic surges occurring because the dopamine dysregulation allows the part of the spinal cord, in fact, to activate the heart, to activate the kidneys, to activate the body, and even the pancreas, that then create things like blood sugar elevations, that create heart rate elevations, that create legs called periodic limb movements. So what we know is that patients that have RLS, or families that have RLS, have higher risks for sleep disturbances, first of all, so they don't sleep well. So things like depression are much higher. Suicide risk, 3 to 4 times higher. This has been found in multiple studies. But also there are biological changes in patients with untreated RLS in terms of what happens with neuroplasticity in the brain. We've seen a number of studies more recently looking at the genomics. What's activated in RLS patients versus people who don't have RLS? Well, it turns out inflammation is activated. There are a number of cytokines associated with restoration and reducing inflammation at night that are not activated in RLS patients properly. So you've been put into a pro-inflammatory state by having RLS that's not treated. So that's one of the things that's really important to know, that this runs in families. It has an unfortunate name, and it has significant association with really bad chronic diseases and problems that are mental health in origin, actually, much more so than we thought even just 10 or 15 years ago. So, there are medications that pharmaceutical companies came up with in the early 2000s that are called dopamine agonists that can actually help to generate some dopaminergic activity in the spinal cord that helps to elicit or to reduce those cortical activity associated with these uncomfortable sensations or uncomfortable movement feelings. But the problem is they have long-term consequences that actually make the RLS symptoms worse over time, called augmentation. So we kind of moved away from those meds, and now there are others called alpha-2 delta ligands, or it isn't in shortage, like Ritalin and things that kids need for ADHD. So you can get this medication, and it's actually improves depth of sleep. So from a lot of that kind of research, we found that it's not just a story about dopamine. It's actually this arousal happening in the central nervous system, that sympathetic surge I was mentioning earlier. That's not necessarily a dopaminergic function. That's actually probably more related to some of the sleep onset chemicals not working properly, like adenosine. So adenosine itself is something that accumulates in your brain and your body as you are awake more and more. When it gets to a certain high level, it activates certain areas of the central nervous system that leads to sleep. These little sleep triggers, like the ventrolateral preoptic area, one of my favorite areas of the hypothalamus. That actually is not working properly in patients with RLS. And it may be related to iron deficiency. So one of the things we know is that iron, as a cofactor in creating dopamine, is a problem in RLS patients. That a lot of patients with RLS actually don't store iron in their cells, in their brain. That means they're not making enough dopamine, but it's also something that affects adenosine as well. And adenosine is what helps to start sleep, and also, we believe, the adenosine response in the central sleep. So if you're sleeping more deeply and you're staying in that deeper stage of sleep, adenosine plays a role there. Well, it turns out in a lot of RLS patients, especially those with lower iron, adenosine is not working like that. And in fact, they're not in deep sleep. They're transitioning, going into lighter stages of sleep and activating things like periodic limb movements while they're sleeping. So it's a little more complicated than just this dopamine story. It's likely adenosine not working well and not activating dopamine appropriately in the spinal cord, leading to this dysregulation. So the story becomes more complicated as time goes, but it's great to learn more physiology and understand that this is not just in your head. This is actually a real physiologic, neurologic condition that can be treated by somebody who actually knows what RLS is, by a sleep practitioner who understands RLS, who has investigated it, and also spent time to understand the neurophysiology. Because, again, like you said before, I'm more of a neuroscientist than I am anything else. I definitely am a neurologist and a sleep doc, but the approach has to be one of understanding where are we with the science and what can I do to activate different parts of the nervous system to help this person, and what things do I want to avoid. Like with RLS, you don't want to take things that are going to inhibit the dopamine system. So compazine, medications that we use for nausea, oftentimes those things can actually make RLS much, much worse. In fact, I can induce RLS in just about anyone with enough compazine.
Wow.
I induced it in myself in my 20s when I was when I was an intern. And here you go, the intern in the ER working just before I went into neurology. I was treating a patient, basically in Philadelphia, in the inner city, a lot of infectious disease. And somehow I ended up with viral meningitis. It was horrible, right? Yeah. So I got tapped.
Oh my goodness.
Yeah, it was terrible. So I had viral meningitis, but luckily it was viral, not bacterial. I was just about to go on vacation. It's like 2 weeks to head off.
Yeah,
only 2 weeks.
That's
in the
why
whole
it
year.
happened, by the way.
Yeah, of course.
Your body was like, stress mode 100%. Now I can downshift. Boom.
Yeah.
Immune system
so
just...
viral meningitis went nuts, and I had to get on a plane and fly to Rapid City, South Dakota, because we were going to the Black Hills. And I did it, like an idiot. I had compazine with me because I was nauseous. And I had the worst headache of my life. Hit the ground, and my wife at the time, she drove us out to the cabin where her family had a cabin. I mean, on the 2-hour drive, we stopped 5 times for me to throw up. It was that
Oh my
bad.
goodness.
It was awful. And so I gave myself a lot of compazine, and I have never had such incredibly bad RLS symptoms. And I can tell you, I can give it to anybody. I don't have RLS in my family either, and I induced it in myself. So anything that's a anti-dopaminergic can do it, but also Benadryl can do it. And in some patients, caffeine can do it, or too much exercise can do it. So there are a number of things that in people with RLS you want to avoid.
And now a quick break. But don't go anywhere. We'll be right back.
Struggling with sleep? Dr. Cole is here to help. Whether you need a comprehensive sleeping coach program, suspect you have sleep apnea, or simply seek a second opinion, she's available for consultations in New Jersey, New York, California, and Georgia, with more states coming soon. Schedule your free 15-minute consultation today to find out which visit is right for you at AskTheSleepMD.com and start your journey to better sleep with a trusted physician.
If you are liking this podcast, if you're finding it educational, if you are feeling more empowered to go to your doctor with any sleep issues that you might be having to address them, please, please, please lend your support. Make sure that you are liking, following, subscribing. I am available on YouTube. I'm also on Apple, Spotify, or wherever you get your favorite podcasts. The website has launched. So we have AskTheSleepMD.com to be your free educational resource. We've added many new blog posts filled with juicy information. If you would like to support the podcast, we now have a way for you to donate. This is a labor of love. I truly enjoy what I am doing. It would be inspiring and truly helpful if you wouldn't mind even so much as donating $1 to keep this podcast going, particularly if you really find this free education a good platform for you and a good resource for you. I also have affiliate links for products that I'm a proponent of, such as Quiet Mind. So please check out the website. Sign up and you will get the latest news, the latest blogs, some sleep tips, and just have a great day and keep listening. Okay, guys, sleep well. So with the caffeine, it would make sense because caffeine basically sort of kind of is like anti-adenosine. So if we already have that being dysfunctional in an RLS patient, that would make sense. It could exacerbate it.
Yeah.
I did want to ask you and just get your thoughts on this because this has always made sense to me. If we know that there is, essentially a paucity of iron and you need iron to make more dopamine, people will eventually develop this augmentation or have worsening symptoms earlier on in the evening, which can happen, over time in as many as 50% of patients. It's very, very common for that to happen. It would make sense because you're sort of just taking a medication, just get more dopamine out there, but you're not really like manufacturing more. You're not getting to the root cause. You're just sort of putting a Band-Aid on the process. I wanted to get your thoughts on that because that's at least intellectually how I sort of process that information.
Yeah. So the way I describe this to patients, especially with the augmentation issue, and over the course of anyone's RLS journey, 5 to 10% of them will develop augmentation especially if they've taken dopamine agonists. That's something akin to putting out a fire with logs. So but again, you can smother a fire with wood, right? Think about it. Like if you're out in the forest, you have a campfire, you put enough wood on it, it goes out, but it's smoldering. And what ends up happening is eventually it's going to flare up into a giant bonfire. So dopamine agonists basically tamp down the symptoms that RLS presents by activating especially D2 receptors and 3 receptors, so different kinds of dopamine receptors. We don't have to get into that conversation, but D2 and 3 receptors are autoreceptors, so they actually shut down excessive dopamine release, which turns out to probably be the problem. So the amount of dopamine is one thing, but it's really about the inactivation of inappropriate overactivation of dopaminergic cells in the spinal cord. So that's one of the concepts behind the D2 agonist working, is it kind of shuts down this dysregulation. The problem is, though, dopamine receptors are incredibly dynamic. So if you keep putting a dopamine agonist into the synapse, into the central nervous system, those D2 receptors downregulate. So that you end up with less D2 receptors over time. And so that's why the dopamine agonist level, you have to add more and more to antagonize what little you have. And that becomes a problem, because now you've created a dopaminergic dysregulation on top of the dysregulation, and that's when the bonfire starts. So you have to kind of get people off their dopamine agonists completely and move into these other things like gabapentin and alpha-2 delta ligands. The other thing that's actually quite effective, and the RLS Foundation has played a big role in the understanding of this politically, is opiates. So long-acting, low-dose opiates like methadone actually have significant benefits in RLS, not just to get rid of pain or symptoms that you think it works that way, but opiate system actually works together with dopamine. And if you activate through a low-dose methadone that stays in the system for hours and hours, you basically can handle RLS symptoms even after having had augmentation for years without any change in dose and without any addiction and without any specific relationship to opiate addiction or opiate use disorders. In fact, that's one of the reasons that we spent a lot of time in Capitol Hill in helping politicians understand that we shouldn't take a blanket approach to opiates, even though we're in an opiate crisis in some ways. We definitely need to understand that in some conditions, like RLS, we're using low-dose, long-acting opiates that have a very particular need to be used. And so that's been a real educational outcome from the RLS Foundation. And I think it's also something for physicians to hear, because when we hear opiates now, we kind of like step back, oh, I don't know if I want to give you an opiate because there is an addiction component to this. But not when you're using particularly long-acting things like methadone in these specific populations. So there's a lot of data showing that even after 10 years of methadone use in particular in RLS patients, the dose change is minimal, if any, and they're incredibly low doses. So that's another really interesting area because it kind of runs into the political issues of the day. And at the same time, I think it's important to understand that the dopamine story and the iron deficiency story that we kind of circa 2008, 2009, we understand that it's now changing in terms of what other aspects of the neurophysiology are actually causing RLS symptoms. So when I look at iron deficiency, when I see a patient for the first time that has RLS symptoms, the first thing we do is check iron levels. We check ferritin, total iron binding capacity. I love to look at CBCs as well, because oftentimes, even if I say to their primary care doctor or to them to talk to their primary care doctor about getting their iron tested, all they'll end up getting is a CBC. And
right.
That's not helpful. And the CBC is helpful, but it's the CBC is measuring hemoglobin, which is the oxygen carrying capacity, which is what iron is actually designed to do in your body. So that's going to be the last thing to go down. For you to become anemic means you got to have very little iron in your transport system and in your storage system. Because if you think about I'm going to protect oxygen carrying capacity, I'm going to take all the iron off the shelves, all the ferritin off the shelves to preserve that. So that's why I want to measure ferritin, because this is a more sensitive measure, not the end product of what we're using it for. So levels actually go up because there's open spaces on the bus transporting. And then the last thing that goes down is the hemoglobin or the hematocrit. So I educate physicians in this all the time, but it's hard because people are used to seeing, anemia, let me look at the hemoglobin.
Right.
That's not what we look for. Ferritin is what we need to look for. And we need ferritin levels to be over 50, over 75 deciliter per milliliter, decigrams per milliliter, because that is really where iron itself starts to cause the dysfunction in the dopaminergic and RLS patient. So 75 is sort of the recommendation right now, and most of this research was done by Chris Early and Richard Allen, who is unfortunately passed away a year ago. But but Chris's work at Hopkins has really led the physiologic understanding associated with the iron deficiency and the effect on the central nervous system, and treating iron deficiency with oral iron, which doesn't work that well, but really with IV iron, which has a significant impact. That's really our first line of therapy.
Yeah, I've definitely done that in clinical practice. And I just wanted to add as well is if you can get your primary care physician, for example, to order the ferritin level, one of the things that I've found is that the normal range in the lab is not something that you can look at. And so I do spend time saying, listen, I know it said it was normal and it's 5. That's actually not good. We want it to be around, 75 or above if we can get there. And yes, to your point, the oral iron supplements too, they can be very helpful. You got to kind of take them with vitamin C to help with absorption, but there can be side effects. So I've had anywhere from, typical would be, oh, my stools, they get constipated, but I've had people actually have like diarrhea from it too.
Yeah.
Where they just feel like
it's not
they're
working. That tells you it's not being absorbed,
basically.
That's the outcome.
Not a good plan. Not a good plan. No. I wanted to just spend the remainder of our time left together, and thank you so much for being so generous with your time and just addressing if there's any other holistic things that we can do. There's been some smaller studies looking at yoga therapy, for example. You mentioned over-exercise. Do you know why the over-exercise may make the RLS worse? Because clearly we talk about regular exercise and stretching before bed as potentially being helpful.
It's not clear. We don't have the actual physiology to say what exactly is happening. One of the things I can tell you, though, from anecdotal and clinical evidence from seeing hundreds and hundreds of RLS patients over my time, is that it's not exercise itself. It's actually high intensity exercise that tends to be the thing in RLS patients that leads to worsening of symptoms. Exercise by itself, low level intensity exercise, sort of the aerobic level exercise, does not seem to be an issue. In fact, it may be helpful in many patients with RLS. Again, there's only a handful of studies that demonstrate either of these concepts. And I certainly wouldn't hang my hat on it from the neuroscientific point of view. But what I've seen many times is that in athletically prone individuals with RLS, that during their high-level competitions, whether they're swimmers, cheerleaders, weightlifters, during those more intense periods, that's when the exercise itself can actually make their RLS symptoms come out. Now, is it possible that it's the intensity of the exercise, or maybe it's the intensity of the moment? Maybe there's actually insomnia that's actually driving sleep deprivation that's causing RLS to get worse, because we know sleep deprivation is a major risk factor for RLS symptoms to occur. It's sort of like epilepsy. We try to avoid sleep deprivation in epilepsy patients because it enhances the opportunity to
risk.
Have a seizure. So I look at it the same way with RLS. We need to improve your sleep itself, especially around these times of intense exercise. And I do this with some of my elite group, that we plan for RLS to become a problem in these periods where you're going to be a little deprived because you've been traveling, because you're in an intense exercise period or performance period. And so what we do is we have medications ready at the hand. And those medications could be gabapentin, could just be dopamine itself, L-Dopa, which is a very fast-acting symptomatic treatment for RLS. And that's where I tend to utilize those kinds of medications that I wouldn't use as a long-term solution, but really for those time periods. So I think of it like that. For the average folks out there, if you notice you have RLS symptoms, or it runs in your family, or you don't know the symptom and it sounds like you might have this, the use of exercise can be helpful if you have an exercise program. But understand, if you're going to do something highly intense, like on a weekend, do a weekend warrior activity, and for 3 hours you're going to play football hardcore, or you're going to go hiking into the mountains and push yourself beyond what your typical limits are, that may induce RLS symptoms, and be aware of that. I think that we don't know enough about the other environmental impacts from the science, but there's certainly a lot of clinical associations that we've been making about things like yoga and Tai Chi, even breath work. If you're using breath work and meditation, that can also put you more into a parasympathetic state than a sympathetic state. And remember, we talked about the sympathetic nervous system activation is another problem in RLS. You could actually potentially use those kinds of interventions for yourself to shut down that sympathetic surge so that parasympathetic activity could take over. You'd have a better night of sleep. Potentially that could be one of the mechanistic associations with things like meditation and yoga and other things where you're using controlled movements and breathing to activate parasympathetic and shut down sympathetic overactivity.
Have you incorporated any of this like newer technology? There's something called Noctrix, which sounds to me sort of like an automatic massager, if you will.
Yeah, there are some of those devices out there, and they've been around for a while, actually. Some more recent ones, like the one you mentioned, that have gotten some FDA clearance to be used in RLS patients. They are basically activating the peripheral nervous system through electrical impulses at the legs in particular, because that's where a lot of people notice symptoms. But you can have symptoms in the arms or any part of your body, actually. It activates those areas so that you're, in a sense, distracted from the RLS symptoms. That's why you use them in the evening and at night, so that that circadian lull where you actually have the problems with RLS. So it's not treating RLS. It's actually a form of distraction therapy that we've used for many years with RLS patients. It's not going to make your RLS go away, and it may not work for you. So it's really something that helps to reduce the symptoms of RLS, but it's not treating the central nervous system in any way. It's not helping to release dopamine. It's just basically helping you to compensate for the symptoms. That's why there have been other therapies that are like, they squeeze the legs, that use pneumatic pressure devices. They help too, but it's only because they're causing this secondary effect where it's making the symptoms feel better. So you're not having to move your legs. It's because one of the things in RLS, it's called the you are me. So you is the uncomfortable feeling or unmanageable symptom of the sensation. R, it happens at rest. At the M is it feels better when you move, and the E is it happens in the evening and at night. So the M, the movement, is now being taken over by these devices. It's adding the M so that you feel better, and it's doing the movement for you. So think of it that way. That's kind of what these devices do.
This has been such a fascinating conversation on so many levels. I cannot thank you enough, Jeff, for your time. You truly are an expert in this area, and I could not have had a better conversation about restless legs. Things that I've definitely learned. I had no experience with the Noctrix system, and what you're saying makes a lot of sense. We had sort of talked about the low-dose methadone, and you had described some experiences using gabapentin, and I've definitely focused on repleting iron storage levels in a lot of my patients with some very good success. And what I can say is that this is restless legs. It feels so much better to have options that are not going to leave people with like worsening symptoms. That was always for years. I was like, oh no, I have an RLS patient. I don't really want to prescribe this dopamine agonist. Like I just, the outcomes are not great, because they may work temporarily, and then over time, what do you do? And then I've definitely seen patients in the office who have been on things for years, and they're like, well, I can just increase this dose or that dose. Now I know that I could probably try some other things, and I feel much more confident about that. So I'm better for this. My mind has been expanded. It's one of the funnest things about doing this podcast is learning new things from folks.
Yeah. Also, I think the idea of RLS itself is something that people have to manage for themselves as well, because us doctors like us, we can provide you, we can navigate, but on a day-to-day basis, we're not with you in your bedroom. So there are resources like the RLS Foundation, which I would actually put a little plug in for here, that you would, as a person dealing with RLS, it's an organization designed to help you. It's a patient advocacy and an information resource for physicians as well as patients. So I would suggest every person dealing with RLS definitely become a member of the RLS Foundation. It's incredibly inexpensive. It's like a couple of dollars a year or a month, and it provides you with the best research, the best evidence. It tells you what's happening, how to get involved, to help yourself, how to join a local group. They have advocacy groups in every major city pretty much. And then where are the best places for those with the most advanced versions of RLS or difficult to treat overlaps with things like depression, where medications actually could make one or the other both worse. There are actual RLS centers of excellence around this country. Not a lot of them. There's only like 12, 13 of them. But if you need that kind of help, you can go get that extra help if you need it. I really think it's a great organization. I've been working with them for over 15, 17 years now. And I think that they do great work. And sort of the unsung heroes in this are the actual RLS patients themselves who are getting involved in advocating for this issue, this serious sleep disorder. Yeah.
This has been amazing. Thank you so much again for your time.
My pleasure. Absolutely.
Disclaimer. The statements made on this podcast have not been evaluated by the U.S. Food or Drug Administration. They are not intended to diagnose, treat, cure, or prevent disease. The information provided by this podcast should not be used as individual medical advice. While I am a practicing sleep provider, I am not your sleep provider. You should always consult with your personal healthcare provider for individual recommendations and treatment.